Thank you all for coming. It's okay, here we go. Is that one? Take it away. So it's my pleasure to be here to talk about my favorite topic, which is wound care. Take it away. And we're going to have about 45 minutes. So I'll try, can you hear me? I will try to not go too fast and yet cover what I wanted to cover. We're going to start with a review of some basic principles of wound care. I'm going to talk a little bit about differentiating different leg ulcers, and then I'm going to finish with tried and true pressure injuries. So just to let you know, one, I like cars. And two, I am the current president of Wounds Canada, which was formerly known as the Canadian Association of Wound Care. It's a non-profit organization, and I have no sponsorship ties to industry. So the objectives, to reiterate, we're going to describe the wound healing paradigm or algorithm to use as a strategy for managing wounds. We're going to differentiate diabetic, venous, and ischemic leg ulcers. And finally, we'll review measures for pressure ulcer prevention. So this is the wound healing paradigm. And really for us who deal with wounds, this is a strategy that we use. People who don't really deal with wounds or know about wounds will come into a room with a patient with a wound and focus on the wound. And what am I going to put on that wound? But really, it's much more involved than that. Okay, critical is treating the cause. Don't forget patient-centered concerns because they're very important members of the team. If they don't buy into the treatment plan, you're not going to be successful. So what does that mean? They need to understand what it is they need to do and why they need to do it. You need to look after their quality of care. What does that mean? You need to manage their pain. You need to give them comfortable dressings. And don't forget to involve family or caregivers. I mean, there's no question that we have a shortage of nurses in allied health, and it's very useful if the family can pitch in. Okay, then we get to local wound care, which involves debridement, bacterial balance or infection, and moisture balance, which is primarily your dressings. I don't think we need to worry about edge of the wound today. That's for wounds that do not heal with appropriate measures that we use. Again, treat the cause is critical. When you treat the wound, look after debridement, infection, proper dressing, all you're doing is optimizing the environment that would allow that wound to heal. But if there is a causative factor that's influencing that wound, it doesn't matter what you put on it. It's not going to heal. So it's critical. So we'll start with the local wound care principles. First and foremost, debridement. So is there slough, debris, necrotic tissue on the wound, or do you have a nice, smooth, pink, pebbled granulation tissue base? Does it look like there's a lot of slough, maybe signs of local infection or spreading infection? And finally, moisture balance. Is there exudate? Is it a dry wound? Is there a lot of exudate and it's very wet? How you're going to deal with this is through your dressings. You want a little bit of moisture. You don't want it dry unless it's a non-healable wound, and you don't want it soaking. So there are many different kinds of debridement, and I'm just going to touch on a couple that influences us here. So why do we want to debride wounds? Well, necrotic tissue inhibits healing. When a wound fills in, the epithelium on the surface The edge of the wound moves proximally to cover. If there is obstacles or necrotic tissue there, the wound will not close. And necrotic tissue is wonderful food for bacteria, so you increase risk of infection. I won't worry about surgical debridement activating wounds right now. Now, eschar is something that we deal with. Eschar usually requires debridement, but not always. If it's dry, if it's superficial, there is no inflammation around it, it's not sort of boggy, you're not worried about infection underneath, it's okay to leave it. It's nature's Band-Aid. It's like a scab, okay? But if it's deep, if there's erythema, if you're worried there may be something going on underneath, it definitely needs to be removed. And if it's covering a pressure injury, it does need to be removed. So there are different types of debridement, and I'm going to mention a few. Autolytic is what we are trying to achieve with our moist interactive dressings, okay? It's nature's way of breaking down debris. There are enzymes that are naturally secreted by the body and would be held in place by the dressings. Mechanical is commonly used, wet to dry dressings, sometimes scrubbing the wound, and good irrigation. I will tell you that we really do not like wet to dry dressings. It is very traumatic, and if you've got a chronic wound that is very slow to heal or start to close, just by taking off those dry dressings, you're removing whatever benefit had occurred. Scrubbing is not good because you're seeding the wound bed with bacteria. You're increasing risk of infection. Irrigation we do like, okay? Normal saline, we ideally want about 15 pounds per square inch of pressure. How are you going to get that? If you're using a commercial preparation in a small bottle, you will achieve it, or you can use a 30 cc syringe with an 18 gauge needle. The only caveat is if you can't see the bottom of that wound, do not irrigate it. What goes in needs to come out. Sharp debridement, nurses that are specially trained, allied health that's specially trained, or physicians will certainly use this as an option. It is quick, it is effective, but it's often painful, and I will give patients pain medication an hour or so ahead of time, and can be done at the bedside. Biological is very nice, it does work. Maggots, but they're specially bred green bottle flies, larvae, not used much in Toronto. There is quite a yuck factor, and you may get some argument. Keep in mind, if you've got a wound that may be ischemic or you're worried about ischemic, in other words, there's a chance that it cannot heal, do not do aggressive debridement. You will just make it worse. Okay? I'm sorry if I'm going a little bit fast. If there's something that you don't understand, please feel free to speak up. So bacterial balance, why do I say balance? Because there's always bacteria, okay? All wounds, all skin, all tissue has bacteria on it. It's okay. If you're not Howie Mandel, don't worry about it. It's perfectly normal. It's not going to harm you, okay? Sometimes you'll get bacteria that start to grow into colonies, but if they're not aggressive, we don't worry about that either. It's not interfering with the healing process. But as you move to the right, so you may get some more aggressive bacteria that start to interfere with the healing process. At the early stage, we would call that a localized infection, usually in the wound bed. If it then progresses, spreading infection, I'm going to talk about each of these, and if it's allowed to get into the bloodstream, we're talking about sepsis and septic shock. You don't ever want to see that if possible. So what are the signs of a localized infection? You're talking about the wound bed per se. It may be something as simple as the wound is not healing. It's not closing in spite of doing everything right. You may have friable tissue, and I'll show you an example of that. Hypergranulation can be a sign of local infection, new areas of breakdown, increased exudate, and it doesn't have to be purulent. If you're just suddenly getting more exudate than you did before, think about local infection. Instead of that nice granulation tissue base with some pebbling, if you're getting deformities with bridging and pocketing, that's a sign of infection. And there may be some foul odor. That type of infection is usually treated with topical antimicrobial therapy, either cream or in the dressing itself. And we'll talk a little bit about that. If you're getting a deep wound infection, well, it's all the classical signs of infection. There'll be increased pain, you'll see swelling, erythema that extends beyond 2 centimeters from the border of that wound, wound breakdown, or the wound is getting larger. If it probes to bone, well, you've got a very deep wound. Think about osteomyelitis, but for sure think about deep wound infection. And you may start to feel a little bit of malaise. This type of infection is usually treated with systemic antibiotics, either oral or IV. If we've got sepsis or systemic infection, these people are very sick. High proportion can die. They go into septic shock, multi-organ failure. These people are in ICU. Okay, hopefully we don't see much of that here. So this is what friable tissue looks like. It's very fragile. You touch it and it bleeds. You'll notice there isn't a lot of erythema around that wound. It's really the wound bed, and you'll see there's pockets and bridges. It's not smooth. This would be a sign of local wound infection. Okay, here is an individual with a neuropathic ulcer. You can see the erythema that's extending, both proximal and distal. We would call that cellulitis, and this patient needs systemic antibiotic therapy, right? That's a deep wound. So again, I say this every time I speak. Sending off a swab and getting a bacterial growth does not indicate infection, okay? Why do we do a culture? First of all, wound infection is a clinical diagnosis. You look at the wound, you make the diagnosis, you're going to start them on antibiotic. We take a swab first in case the antibiotic we choose isn't really doing much in 2 to 3 days. By then we'll have the sensitivities back and maybe there'll be another antibiotic that's more appropriate. Okay? Wounds that are less than 4 weeks, think about gram positives. If it's beyond that, you're starting to get chronic as well as positives. You'll have gram negatives and anaerobes. So you'll need more broad spectrum treatment. I'm not going to talk about the creams today, but we do have a number of different kinds of dressings that are very effective antimicrobials that are good for local wound infection. And ionized silver, povidone iodine through different release mechanisms, and PHMB, which is polyhexamethylene biguanide. It's a chlorhexidine derivative. So all of these are broad spectrum. They do not generally cause allergic reactions or non-sensitizing, and they are not cytotoxic. They are safe to use on fragile wounds. So ionized silver here, we may have Acticoat, silver cell. We have any dressing that has AG or silver after it. And in terms of iodine base, you could use betadine, but that's not slow release. We often use inidine iodosorb, both very effective. Iodosorb I tend to use if there's some slough or some debris you want to clean out. Otherwise, I tend to use inidine. I will tell you, inidine is significantly cheaper than iodosorb. Okay, and the PHMB, they're usually embedded into dressings or ribbons. The common one that I use here is AMD ribbon, often to fill cavities. It will have antimicrobial properties as opposed to just ribbon gauze. And not expensive. It's been around for a very long time. Any questions about that so far? Okay. Now what you've all been waiting for. Which dressing do I put on the wound? Well, unfortunately, I cannot tell you which dressing because there are over 4,000 different dressings. Okay, so we talk about principles and we talk about categories. Okay, so here are some basic principles. We want an occlusive dressing because you want to maintain optimal moisture on that wound bed and you want to keep bacteria out. Okay, if a wound is dry, we want to add a little moisture. So think about adding a little bit of a hydrogel, not a half-inch layer. Okay, if there's exudate, then try to match a type of dressing that will absorb. If there's a little bit of exudate, there are a number of choices of dressings. If there's a lot of exudate, you're going to primarily use a foam. And I will talk about the different absorbencies of the dressings. Because if there's too much drainage and it's leaking out, you're going to get peri-ulcer skin maceration, which is that white or irritated area around the wound. And the bacterial barrier is lost, right? You want to eliminate dead space, wound dead space. If you have a cavity or if you have a sinus, you want to loosely fill that with some material, some gauze or alginate or hydrofiber. Why? Because you want that wound bed to rise and reach the surface before it closes over, right? If you don't do that and the surface closes over, sometimes you'll be left with a cavity underneath, and that is actually high risk for infection, and that is not a healed wound that's going to break down again. Okay, so there isn't one right dressing. There are numerous dressings that are acceptable for treating a particular wound. There's also some specially shaped dressings we'll sometimes use on a wound on a heel or on a coccyx. It's just more comfortable, fit better, okay? And when you're picking a wound, consider how often you need to change the wound. The ideal is 2 to 3 days, but sometimes we can't achieve that because of the amount of drainage, right? So you want to get a high absorbency dressing on there, right? So from bottom to top, least absorbent is bottom, most absorbent is top. Hydrogels, well, obviously that's actually adding moisture, okay? Films, such as, for example, Upsite, absorbs nothing. Not great for putting on an open wound. Where do we use it? If you have a recently closed wound that's maybe a little bit fragile, you may put an Upsite over it to protect it. Sometimes you'll put an Upsite over elbow or heel to prevent friction if they're using that to move up and down the bed. Okay. Hydrocolloids are definitely an option. We don't use them too much anymore. They just absorb a little. Dressings like Duoderm, they do exist. They are around. Acrylic dressings are sometimes dressings you can see through. They'll absorb a little bit more. But the top 3 are the ones that absorb most. So alginates are seaweed. We use them to fill wounds. They're highly absorbent. Keep in mind you have to put a dressing on top of it. Also with hydrofibers, an example would be Aquacel. Highly absorbent, fit into a wound, need a covering on top. And finally, what we often use on the top of a wound are the foams. They're generally highly absorbent. Okay. Sometimes, as you will see, we'll use something to fill and something on top, but you don't want to put 3 or 4 different types of things in a wound. That's just like making a sandwich and spending a lot of money. Okay, and I've talked about this, the different types of dressings. So let's, yes, Jeffrey.
How often do you change the foam dressing?
Well, ideally 2 to 3 days. If there is a tremendous amount of exudate, you may have to do it more often, temporarily. You try to get the exudate under control, be it local infection or whatever. If you have an infected wound, you may do it more often. But if you have a wound that's healing well, the ideal would be 2 to 3 days. So we're going to spend a little bit of time talking about the different sort of leg wounds that we do see here at St. John's. 3 different kinds. First, a little bit of a description. So we're talking about venous leg ulcers, arterial or ischemic ulcers, or neuropathic, which would include your diabetic foot ulcers. Okay, so go down to ulcer location in the middle. So venous ulcers tend to be the lower third of the lower leg, above the ankle, around the ankle. Sometimes if you get trauma a little higher, it can be anywhere on the lower leg. You rarely see it above that level. Look at the skin around a venous ulcer. You may well see varicose veins, hyperpigmentation. Sometimes there's some scarring, which is known as lipodermatosclerosis. And there's often a tremendous amount of edema. Okay. The ulcer itself is irregularly shaped. They tend to be shallow. They can be quite large, and they're usually quite clean looking. There may be some slough, but they don't generally look infected. Okay. The pain with these type of ulcers, sometimes there's not so much pain, sometimes there's pain. If you palpate it, it tends to be uncomfortable, but pain is decreased with elevation. Okay. In arterial ulcers, they're distal, so often feet, toes, they tend to be round and punched out. They tend to be dry. Okay, look at the skin around. They talk about ischemic legs having thin, shiny, hairless skin. When these legs hang over the bed, they tend to be cyanotic. Okay, the pain can be really quite serious, knife-like, and worse when you elevate it, because when you hang the leg down, gravity improves the blood flow, right? And neuropathic, why didn't I call it diabetic? Because this type of ulcer is because of loss of sensation. Diabetic ulcers have loss of protective sensation, but there are other causes as well. Okay, you could have idiopathic peripheral neuropathy. Those people are just as likely to get these ulcers. They tend to be on the plantar surface of the foot over prominent bones. These ulcers are from repetitive trauma, okay? And because of loss of sensation, you tend not to feel it, okay? They are round and they have a tremendous amount of callus that develops around those wounds. That callus has to be removed because that adds 25% pressure to those ulcers. So let's go back to treat the cause. Venous ulcers, yes, you've got to put a dressing on it, but unless you're able to provide some compression, you are not going to close those ulcers. Why? Because of increased venous pooling in the leg, blood and proteins leak out. When the blood is resorbed, it leaves the iron behind, and that's a pigmentation. That's like a tattoo. That's never going away, okay? And the proteins that leak out cause inflammation and ultimately breakdown. So the way to counter that is by applying compression. Sometimes you're limited because if they have an ischemic leg, you may not be able to. Okay. Arterial, well, you know, unless you can improve the ischemia, either angioplasty surgery, you're not going to do much for those people. And neuropathic need offloading. Okay, you may have to deal with ischemia, you may have to deal with infection, but most critical is offloading. Get the pressure off of that area. So that's an example of a venous ulcer. It can be quite large, irregular border, tend to be shallow, often a lot of drainage. It's serous, and that's just because there's so much fluid in the leg. It has a way to get out. It's like a gate. Okay? And often you will see swelling, hyperpigmentation, maybe varicosities. Ischemic, well, you see some gangrene. You see the punched out ulcer here, here, here. They tend to be dry and punched out. They tend to be distal, no hair. You have dystrophic nails. Okay, I will tell you that this was the result of compression put on someone who didn't have their arterial flow checked. And this is a neuropathic foot ulcer. You'll see it's over the head of the first metatarsal, a prominent bone, tend to be round. You'll see the callus around there. And that forms very quickly. Needs to be debrided off about every 3 weeks or so. But the critical thing is the shoes, the orthotics, it's the offloading. Right? So don't forget, treat the cause. It's crucial. So, quick review. I'm sure you all know all about pressure injuries. And just a quick review of staging. We have stage 1, 2, 3, and 4. We have deep tissue injury and unstageable, which used to be known as stage X. And we're going to show examples of all of these. Remember that this type of staging is only for pressure injuries, not diabetic or venous ulcers. It's only for pressure injuries, and you never backstage. So if you've got a stage 4 that is closing up and it's all looking like a 3 or a 2, it's not a 3 or a 2. It's a stage 4 that's healing. Why is that important? Because the original wound will tell you, once it heals, what kind of tensile strength is in that wound. If you have a stage 4, you've lost about 20-25% of the tensile strength. In other words, that area will always be susceptible. So this is a stage 1. Erythema, no skin breakdown. What you do is take the patient off of that area, take the pressure off, wait about a half an hour. If there's still erythema there, that's a stage 1 pressure injury. Okay, stage 2 is just into the dermis. It's very superficial. There is breakdown in the skin. Okay, stage 2 pressure injury. Now, this is also a stage 2. You often, not often, sometimes we'll see it on a heel, a blister. That is a stage 2 pressure injury. So how do you tell a stage 2 from a stage 3? They may both be pretty shallow. Well, in a stage 2, you see how clean that was? Here you see some slough, some adipose tissue. Stage 2 has no adipose tissue, so unlikely to have any slough. You may have a little bit of exudate, serous, but you should not have any debris or slough. And there's not usually any mistaking of a stage 4. You're through the fascia. You can see either muscle, tendon, bone, ligament. That's a stage 4 on a coccyx. Stage X or unstageable, I don't know what's under there. Okay, and you cannot really stage it until that is carefully removed. So it's just unstageable. If you're saying you have an unstageable pressure injury, that automatically means somebody needs to debride that. And this is a deep tissue injury. It's not all that common, but we do see it, and often presents as an initial bruise. And what will happen is you'll come back a day or two later, and all of a sudden you have a deep pressure injury. You say, what the heck happened? So that bruise is actually a sign of already injury. It just hasn't broken the surface. Here you can see it's already liquefying, and it is going to open up into likely a stage 4. So at this stage, we call that a deep tissue injury. It will then be staged as something else when it opens. This type of injury is usually the result of shear, right? So transferring in the bed, or someone who's sitting up in the bed, and what will happen is the skeleton, their body will sink down, but if there's a little moisture on their skin, sometimes it stays up. So you got that shear, and before you know it, you've got a significant pressure injury there. So someone who's really at risk, you don't want to keep the head of the bed higher than 30 degrees. So prevention, that's the name of the game. All patients who come in here need to be checked from head to toe. If we miss a pressure injury within the first 72 hours, we own it. In other words, it happened here, whether it did or not. Every patient receives a validated risk assessment tool assessment. When in our place, it's the Braden scale. So all new admissions and at regular intervals. And if you've determined that someone's at risk, well, you need to do something with that. You need to document interventions. You need to pass the message on, primarily to your occupational therapist, okay? Because offloading is critical for these people. Don't forget the physician too once in a while. So, different areas. We don't have these separate mattresses, but we have alternating air mattress beds. And if you have someone who is high risk, this is certainly an option. We don't have a lot of these beds, but they are available. Keep in mind that transferring out of bed may be more difficult for these patients. And some people get motion sickness, so you may have to use something else. Again, positioning, turning to the side, 30%, 30-degree side lying from time to time if you need to get off the coccyx. Okay. And don't forget about shear. And we have trapeze bars. We may need to use a transfer lift sheet. We have Hoyer lifts. And don't forget pillows or wedges to shift the patient's weight from time to time. And this is the perfect way to get the family or caregiver involved. They can certainly help out with doing this. And for heels, there are numerous types of boots that are available that will take the pressure off the heel. We do have some in-house. Occasionally, patients or families will buy them, and very good for taking the pressure off. If they don't have the money, or if we don't have any available, you can roll up some towels or sheets to put under the calf to raise the heel. Okay. But treat the cause, #1 priority. So a couple take-home messages. Think about that wound healing paradigm as a strategy for treating your wounds, the things that you need to check off as you're assessing these wounds. Treating the cause is usually the most important factor in getting a wound to close and heal. And wound care is ideal for an interprofessional team. That's why this is a wonderful facility for dealing with wounds. And I have a bit of a chronic wound program on my floor, and this program's been touted at the university numerous times. Yeah, you all know the objectives. I just want to spend a couple of minutes Wounds Canada programs. Okay, so the Canadian Association of Wound Care is now known as Wounds Canada. The site is woundscanada.ca. You're all welcome to go there. Yes, you may become a member. It's a good thing to do. There's discounts, but even if you don't, you are welcome to go. Why? Because there's all kinds of wound care resources and news on the website. You can sign up, even if you're not a member, to receive free publications on wound care or Diabetic Foot Canada. And there are best practice recommendations that were updated just within the last year or so. It's free. You can read it. You can download it. You're not going to get better, best evidence-based, best practice information than this. There's new ones coming out. These are the ones that are already done. There are conferences. The next week is the one in Winnipeg. There's 2 a year now in Canada, one always around the Toronto area. So in the fall, November 8th to the 11th, it's going to be in London. If you have an interest in wound care, it's a great place to learn and to network with other people who also are interested in wound care. And just you are the first to hear about this. Going to be released later this month is the Wounds Canada Institute, and it's for education. There's a whole bunch of modules that are going to be available to do online. There's a small charge to do them. You'll get educational hours for doing it, and you can go through a whole sequence and develop an expertise in an area. So that's coming later in May. Also, not just for nurses, for allied health and physicians. Okay, so I thank you. Any questions? I did have a wound that we could talk about, but we'll have to save that for next time.